this again is one of our most favored visiting professorships and lectureships. We use this time to honor one of our distinguished former faculty members, Dr. Jim Goodnight, who's been in the UC Davis family. I was doing the math, almost 40 years now. And he gets younger every year, so it's just amazing. I don't know. I think it has something to do with good wine and good travel, but that's a separate conversation. For those of you who don't know, Dr. Goodnight was the department chair. He actually came here and started the Cancer Center with his colleagues in internal medicine in the early days of the development of UC Davis, then went on to become the department chair. He was department chair here for 12 years before he was tapped to develop the practice management board and really evolve our practice organization more into truly an organization, which is that legacy is still in evolution today, but really has helped transform the university. So it's with great pleasure that we honor him through this annual lectureship. We have traditionally focused on honoring your legacy as a surgical oncologist, so we use this as an opportunity to bring distinguished colleagues here. And with that, I'm going to ask Dr. Bold to introduce this year's Goodnight lecturer.
I think everyone can hear me without a microphone. It's a pleasure to introduce Karl Bilimoria. Karl's resume is enormous. I could spend the next hour introducing him and reviewing his accomplishments, but a couple of highlights. So he received his medical education in Indiana. He was actually a native of Indiana. He went to Northwestern for residency, did some time at the NCI, and then surgical oncology at MD Anderson before coming back to Northwestern, where he's been on faculty since then. A variety of leadership roles at Northwestern. He is the vice president for quality for the entire Northwestern medical system. He's the vice chair for quality within the Department of Surgery. I think a couple of really big things that have illustrated his leadership. He runs the Illinois Surgical Quality Initiative Center, which is a group of over 150 hospitals in Illinois that is aligned to improve the delivery of surgical care in the state. He also is a co-director for the Northwestern Comparative Effectiveness Research Center. He's authored more than 350 publications, including things in JAMA, New England Journal, extremely well funded by the NIH and AHRQ to study quality and change how we deliver surgical practice to our patients. And then most recently, as of about a week and a half ago, the new president of the Association of Academic Surgery. So it's an extreme honor and pleasure to introduce colleague, friend, and national thought leader in surgical quality, Karl Bilimoria.
All right, well, is this working? Can you hear me? Okay, great. Well, thank you for the invitation. It's really nice to be here and see so many friends. Thank you, Dr. Farmer, Dr. Bold, and certainly thank you to Dr. Let me see. Fix this. There we go. Thank you to Dr. Goodnight. We had fun at dinner last night. We were joking that it's really nice to give a lecture that's where the person being recognized is still here. So, glad you're here. All right. So we have a big team that does health services and quality improvement research for more than 45 people in our center, and they do all the work, and I get to go fly around and talk about it, so I just want to recognize them up front. We do a lot of different things in quality and safety, and this work in education initially started as a safety piece, right? So if we train residents differently, does it result in a difference in patient outcomes? And now it's transitioned into a lot more, and I'm often talked about as the duty hour guy. And I don't know, hopefully this is still about quality and safety, and I'll talk to you a little bit why we think that. We do have a lot of training opportunities. We run the ACS quality, the Clinical Scholars Program, so if there are residents who are interested in working at the ACS, please definitely let me know. It's a 2-year research training program. And if you're not part of the Association for Academic Surgery and you're a young surgeon within the first 12 years of your faculty life or as a resident or medical student, the whole point of this group is to advance young surgeons and develop leadership opportunities and professional development. So I'd highly encourage you guys getting involved. It's a lot of fun. We have great parties too. So. All right, so let me talk a little bit of background on the first trial. I'm not going to go very deep into the first trial, just to tell you why some of the things that have happened since the papers came out and why it's taking us toward the second trial. So this was just a little background. This came out from the ACGME themselves. They did this meta-analysis and they looked at studies. Single institution studies on the left and national studies on the right, and they looked at whether patient safety got better, no change, or worse. And the blue diamonds are the surgical studies, and you can see that they're mostly toward the no change or worse. And so they were concerned that maybe the 2003 duty hour policies had made things worse. This is what they were trying to examine here. We followed this up with 3 studies and then another study from Penn that looked at the 2011 changes and found that there was no difference. And the big 2011 change was the 16-hour rule for interns, and we wouldn't expect that to have much of a difference. The other thing, as the ACGME was talking to us about an idea to come up with a better data for duty hour policy decision making, they were getting pressure from Congress about the European Working Time Directive. And this is not just in medicine or in surgery, this is across the entire EU, where you can only work 48 hours, 13 hours max, and you need a 20-minute break. So you gotta scrub out, take a little break, and then come back. So it doesn't really work real well in surgery, but this is what they were getting questions about. So moving from 80 hours down to 48.
Calm down back there.
No, was that a request to work only 48 hours?
Yeah.
Okay.
We might have to cut it.
Then your training would be 10 years. So, so there were no randomized trials to base their decision on. Certainly no large national trials. And so we formed the first trial. And very briefly, we randomized 120 programs, 150 hospitals overall, standard policy or flexible policy. In flexible policy, we waived some of the duty hour requirements. What arm were you guys in?
Flexible.
Flexible, it's good. My chair was really mad when we got the control arm. So we collected data, and then we looked at patient outcomes using the ISQIP data between the 2 arms to make sure everything was safe. And then we were really interested in resident outcomes as well. So resident well-being, education, did they like flexibility, how did they use it? And we studied all of that through the ABSITE survey. So thank you to all the residents for so many years of completing this survey. It actually results in something, and I will show you a lot of that detail today. These are the changes that we made. We did not change the 80-hour work week, 1 day off in 7, and call no more frequently than every 3rd night. Those were the same. But we did get rid of the 24-hour cap and the 16-hour rule for interns, and having 8 to 10 off between shifts, because those things prohibited your continuity of care. Right, so they interfered with day-to-day continuity, whereas the 80-hour work week really doesn't overall. As everybody knows, I think by this point there was no difference in patient outcomes between the 2 arms, no matter how we looked at it. Any outcome that we looked at was pretty similar, so it seems safe to allow flexibility. It started to get interesting as we looked at the resident survey results. So certainly no difference in quality of resident education. But when we looked at overall well-being, there was a slight difference. So everything here is framed in the negative. So percent who are dissatisfied. So slightly higher proportion were dissatisfied with flexible policy well-being, but it didn't quite reach statistical significance. We'll drill down on this a little bit. Where we did see big benefits was in the ability to offer continuity of care. So this was a staggering number. 13% of residents in the standard arm said they had to leave in the middle of an operation because their duty hour clock was up. Clearly not something that we want. We've been able to drop it to 7% in the flexible arm, and now after multiple years of flexibility, it's gone down to about 3%. So it seems like a better number. Missing an operation on a patient well known to you. We all want to operate on people that we did the consult or that we've been taking care of all night. We want to stay to do that case the next morning. That is better with flexibility, and also handing off patient care issues got better with flexible duty hour policies. So this is where you might recognize Tony. So I was, this is the first time I think I've seen Dr. Bold without him swearing at me for taking Tony Yang away from you guys. But Tony's wife is happy being close to his family. So.
For those residents who don't know, Dr. Yang was a faculty that was here. Dr. Goodnight recruited him, and he is now at Northwestern doing this same research under Dr. Bilimoria.
Yep, yeah, so he's doing well. He just got his K a couple weeks ago. Anyway, so he did this work. We asked residents if you could go back and pick what kind of program you would like to be in, flexible or standard. Most of them, the vast majority, were either positive for flexibility, that's the dark blue, or neutral. And if you experienced flexible duty hour policies, you were even more favorable and thought it was more important. There was an important age effect as well. As you moved on in your residency, you were even more enthusiastic about duty hour policies, and only 14% wanted to stay with the standard. And so I will tell you that this is where sort of the residents spoke, and the ACGME looked at this, and this really helped to drive the policy change. They really thought this was pretty powerful data. Well-being improved by PGY level. The red is the flexible and the blue is the standard. There's still a big delta. The well-being was definitely different in terms of health, rest, and time with family and friends. But it got better, at least your perceptions of it got better as you got older. But overall well-being, when we looked at it, it was only thought to be worse in the interns. But as soon as you got to the more senior years, the flexible policy was actually a little better. So people appreciated flexibility as they got older, and so that's sort of the finding that also led us to believe it was worthwhile to pursue flexibility. There are things that you don't hear about when all these trials happen, and so I want to talk a little bit about the opposition. So even before we started the study, we wanted to get New York in, but in New York, duty hour policies are written into state law, the Bell Commission laws. And so we had to get a waiver from either the health commissioner, but he's a politician, he did not want to touch this at all. He took one call and was like, no chance, and it was over within about 5 minutes. So, but Fabrizio Nicolasi, who is the chair at Cornell, has a lot of powerful friends. So he was able to convince a state senator to write a bill that said if you're participating in a national trial sanctioned by the ACGME, we would waive the Bell Commission rules. And it passed the Senate in about a day. It's one of the fastest pieces of legislation I've ever seen. And it had to go to the Assembly. And Dr. Lewis, who is the head of the American Board of Surgery at the time, was supposed to fly out and answer some of their questions. And the night before he was supposed to go, they just canceled. They said, no, thank you. We don't need you. We're not calling this meeting anymore. No explanation. The next day, this came out. A memorandum in opposition from the resident union. Are you guys unionized?
No.
Okay, good. So I can talk about the union. Okay, so.
Not yet.
I'll be careful. All right, so they said essentially that New York does not need to subject its patients or physicians to future studies, that's us, that may well put both in harm's way in order to learn from future national studies. Basically, they threatened to strike if the Assembly took this up, and everybody in New York dropped it. So New York was out. The unions were very powerful. This happened after we had finished our year of data collection with the first trial. So Public Citizen, which is the watchdog group, American Medical Students Association, and the union filed this formal complaint with the Department of Health and Human Services that said that the first trial was unethical. It was conducted in an unethical way, it failed all these IRB protections, and what had happened was, in the year after we finished, the internal medicine trial started. And a lot of the internal medicine residents were not happy about that. And so those complaints led these groups to really start to pay attention. They complained about that trial, but they complained about our trial even more. And there was one primary complainant on this, and it made the newspaper in my hometown. Bilimoria conducts unethical trial, and it made my mom super proud. But it all did blow over. We had discussions with Health and Human Services. The secretary got involved. Everybody was fine with what we had done. And the big part of this was that the chair, the program director, and the DIO, who's in charge of GME at each institution, had all signed off at 120 different places. So about 500 of us would have had to have a lapse in ethics for this to have gone through. So anyway, we did take good protections in place. ACS, RAS, Residents and Associate Society, came out in favor of the first trial and how it was conducted, and the importance of flexibility, and that really helped the ACGME make this policy decision. And what's striking is you would think that the ACGME would sort of move at a glacial pace, but once they saw these data, they, within a year, basically had changed policy. They had put together a task force, gone through a pretty formal process pretty quickly, but basically built in flexibility exactly as we had tested it in the first trial. So let's talk a little bit of what's come after that. Flexibility, I won't go too much into the details, but I will tell you that over the 4 years of time that people have been in the flexible arm, things have been fine. We haven't seen a deterioration in resident well-being or in patient outcomes. So this is the iCompare study, and today's Wednesday? Tuesday. So I think tomorrow, I don't know for sure, but I have a suspicion that tomorrow the results of this will come out in the New England Journal, but no, not sure. But what they did was they did a study that was similar to the first trial. The amazing thing is they started, any internists here? Okay, so they started this trial 7 or 8 years before we did, thinking about it, how they might do it, and then we just sort of thought about it, and within 4 or 5 months we were enrolling programs and sort of beat them to it. And so they laugh about it too. It's very stereotypical, right? A bunch of internists overthinking it. And so the ACGME said, well, why don't you use the first trial design and the changes that they're making? And they said, okay, fine. So they did that, and they were able to start the year after. The problem is they don't have NISQIP, so you have to rely on Medicare data, and there's a huge lag in Medicare data. It's not nearly as good. It doesn't have the details, so really mortality is their primary outcome. So that's why they finished in 2016, but they're still just getting ready to publish their outcome data. They did publish their resident survey data, and this got a little bit interesting, so let me walk you through this a little bit. So this was the commentary that came with their paper in the New England Journal. And this is the internal medicine study, and then this is our study. And so what you'll see is that overall well-being, they had their residents were really unhappy. 30% of them were dissatisfied in the flexible arm compared to 15%, whereas for us, that was a very small delta. Similarly with quality of education, amount of time for rest, they thought flexibility really ruined their lives overall. They didn't like the regulations at all, work hours and scheduling. And so overall, they just did not like flexibility. And I think that was evident because only 60 programs out of the 400 or so internal medicine residency programs signed up for the iCompare study, whereas in the first trial, basically every program in the country was included. So this shows you that they have a different view. And this shows you even more. You guys know what SDN is? This website where residents and medical students can go to learn about other residency programs when they're applying. This person is particularly interested in internal medicine and comments that they're a little frustrated that this is being implemented when I start residency in 2015 with no prior warning or opportunity for input. Welcome to the rest of your life. But and this internal medicine person is, on the surgery forum, the residents are oddly excited. So now the ACGME is in a tough spot. They have internal medicine residents not liking this. They have surgery residents liking this. And I suspect the data that comes out will show no difference in medicine patient outcomes. And so, in fact, this Saturday, the ACGME is reconvening a task force to start talking about what to do with duty hour policies for internal medicine in particular. They think there'll be separate rules for medicine versus surgery. So we've continued to learn from residents. The resident voice was very powerful in all of this. And every time we do the survey, we'll go back and we'll interview residents. Some of you, I think, have been interviewed by our team to learn more and understand what the results actually mean. And then we redesign the survey the following year to sort of follow up on that and get even more into it. And we've created this great surgical education trials group, essentially. There are 150 programs. We'll have even more now. The DO programs are now in the ACGME process, so we're up to 312 programs total. And the first trial has shown us that there's no difference between study arms for a number of things. And duty hours were not the main driver of burnout. So let me show you a little bit about that. We moved into quantifying burnout and well-being. We do a standard burnout inventory as part of the ABSITE survey. And we've seen these studies in JACS that say 70% of our residents are burned out. It's a pretty high number. So in our data, in most of those studies, the response rate is low. It's like 20 to 40% at the best. And there's a huge non-response bias. So what's that 60% of people who aren't responding? Are they the happy people, or are they the really, really burned out people? It's hard to know, right? So here's what we found. Depending on how you do this, so burnout is, that scale, if you go back here, is measured how often you experience any of these findings. And these are 3 different domains: emotional exhaustion, depersonalization, and personal accomplishment. We all do really well on personal accomplishment in medicine in general, so that's not a huge one. The other thing that's been, you have to have both of these to really flag positive for burnout. And if you use the OR operator, you can drive that number up. If you say weekly symptoms and make it one or the other, you can get close to that 70% number. But really what it's supposed to be is that you have to have both of these. You can pick any time interval you like. We think weekly symptoms are probably the most sort of concerning, right? Obviously daily are terrible, but monthly, everybody, there's, the monthly rate may not be as much of a problem, but the weekly one is really bad. So we call our rate about 22%. The other thing that we looked at was psychiatric well-being. This is a standard instrument that, if taken now, predicts your chance of developing non-psychotic psychiatric issues in the future. And 43% of our residents flag positive on this in the country, which seems like a pretty high number. We'll have to see if that bears out. Maybe, I don't know if the scale was totally designed for people in surgical training, but it seems too high, right? I don't think that's necessarily true, but it's something to monitor for sure. All right, so here's some of the factors associated with burnout. In the PGY 2-3 year, that is an important point, and those people are more likely to be burned out. No difference by first trial study group. Sorry, these boxes got skewed somehow. And the number of number of months that you violate the 80-hour rule significantly increases your burnout. And we've seen this in everything. You're going to see this on all the slides I show you. It adds, it's a negative for pretty much everything from needle sticks and car accidents, all that sort of thing, as soon as you start going over 80. And so there's a new group at the ACGME, the RSC talked about it a couple weeks ago. They're going to enforce the 80-hour work week with vigor. So there's going to be really a no tolerance policy for this. So I would just make sure you guys are on board and or in line as much as you can do. The other thing that we saw that was really interesting is feeling prepared for residency. If you weren't feeling prepared, you were more likely to be burned out. And what was that driven by? It was the number of calls you took as a medical student was one of the most powerful predictors, because that gives you a realistic sense of what it's like to be a resident. It gives you the choice to opt out of surgery and say, this is terrible, I'm not going to do that, and go into medicine. Or it helps you learn about how to handle yourself when you're tired. And so I think making sure that our medical students get a realistic experience is a key piece of helping to avoid burnout. So more to come on that. The Council of Deans is actually taking that up because so many medical students or medical schools have stopped having medical students take call. All right, so we'll talk a little bit about this gender discrimination and sexual harassment in surgical training, and because we found in the interviews that this was one of the drivers of burnout and well-being. Many things contribute, but this was one of them. And so we wanted to dive into this a little bit, especially given the current environment. So here are the rates. Again, with this survey, we have a 99% response rate. We don't have a non-response bias, essentially. So these are the best data, probably in medicine, that we've seen yet. So 65% of female residents reported gender discrimination. 20% reported harassment. Pregnancy and childcare discrimination, these were the rates. Unfortunately, we didn't have the denominator. We always make a mistake on the survey. I always forget something. Blame it on myself. But this year in the survey, we got the denominator, so we'll be able to report that. But same thing for racial discrimination. Verbal and emotional abuse is roughly equal between the two groups, and luckily physical abuse is relatively low overall, although it does occur. So here's where, these are just the general rates. Luckily, most of this is in the few times a year to a few times a month. Certainly for the sexual harassment, it's not a weekly or daily occurrence, but just gives us some idea of how often it's occurring. Here's where I thought it got really interesting. We asked them, where did it come from? And my prior was that it was probably all from the attendings, right? So it turns out that usually gets a bigger laugh, but okay. So, all right. So it's always funnier in my head, but it turns out it wasn't, and it's from a lot of the gender discrimination was from the patients and family. And to me, that was really eye-opening, because that changes the solution. If it was a bunch of attendings, we could get together, we could work together, we could do training, we could threaten them, whatever it is, but we could figure out ways to deal with that. But if this is society, right, so it totally changes our approach to solutions. So we'll think about that a little differently. In sexual harassment, it was more equally distributed between patients and attendings, a little less for the co-residents and nurses and staff. And then childcare discrimination, again, was mostly amongst coworkers, attendings, and co-residents. So this gives us some idea of where to go when we think about solutions for this. The gender discrimination was more likely as you got older in your residency, and at first we thought this was because of the way we asked the question. We asked it about during your residency. So of course, older residents have a longer time horizon in which to experience this. But when we did the interviews afterwards, the female residents said, no, this is about familiarity. People are more likely to sort of do some of these things as they know you, particularly for the sexual harassment models. But we see this in all of the models. The Northeast is bad, no matter how you look at it. So my partner in crime on this is Yaron. She's a pediatric surgeon, and she trained in the Northeast in Boston. She said, no, we just have higher standards. We just wouldn't put up with something like that. So I don't know which one is right. It's impossible to tell from these data, but it could be a reporting difference, that they have a lower threshold to report these things. But it's worth following up on. The other thing we looked at a bunch of different things. The gender of the chair, the program director, the percent of the residents who are female. We looked at the proportion of the faculty who are female. And we did see this, my PowerPoint version and your PowerPoint version did not get along here for some reason. It's in this fourth group, actually, where we see a threshold effect. And as you have a certain number of faculty, you're actually more likely to report gender discrimination. And we think that's because of some comfort level and being willing to report at some particular level, not that that actually is a predictor. So complicated data to work through. This childcare discrimination, again, the Northeast doesn't do well here. And similarly, we see this threshold effect. And then in sexual harassment, we know that being married is protective. That's been well established. You're less likely to experience sexual harassment. But again, the Northeast stands out here as well. Again, this age effect also occurs as you get older. It's considerably higher risk of sexual harassment as you get on in your residency. One of the things we saw, these are program level rates of each one of these exposures. This is a box plot, so this is the median, the interquartile range, 95% confidence interval, and some outliers. And there's a pretty big spread in programs, and there are some that have almost none of these exposures. So it led us to believe that changes may be possible to improve the environment. So this gave us some idea that we should probably go look at the good performing programs and see what they're doing on each one of these. We looked at the correlation, though, between sexual harassment and discrimination. We thought if you're bad at one, you're probably bad at everything, right? All of those exposures happen. It's not true. There are no associations. Each one of those events is separate. There's a separate sort of culture and environment that seems to predict how that has happened. And so it's going to say each one of those are going to have to be handled separately. So we put all of this together finally in the following year, and Ryan Ellis is one of the ACS scholars and a Northwestern resident put this together. So initially, when everybody looks at burnout, and this is sort of dogma in the literature, that women experience higher rates of burnout than men. We also did a severe stress scale. This is a pretty standard scale. That predicts more burnout, as does low grit. So we use the standard grit scale amongst the residents. If you're at low grit, it makes sense that you would have a harder time. And then duty hour violations again. But what's interesting is when you add in the sexual harassment, the abuse, and the discrimination, and we put it all together. You can do this separately. It all looks the same, but for presentation's sake, I put it all together. Certainly that increases your risk of burnout. But what's really interesting is that it flips the finding for women, where women are actually less likely to be burned out once you consider these other exposures. So it's kind of an interesting piece, and totally changes the way we should probably think about burnout amongst women. We looked at attrition, thoughts of leaving your program. We can't study the people who have left, but we can study the people who have thought about leaving in the last year, or the suicide rate. 12.5% in the country thought about leaving their program. The suicidal thoughts is 4.5%, which is identical on this survey instrument to the national average. So we're just about the same. But there's no difference by gender. Higher risk if you're burned out, experiencing severe stress, If you are low grit, duty hour violations, and again, the discrimination and harassment. So similar themes for all of these. So I guess the question is now what? We know burnout is a problem. It's hard to solve. We don't have data. We don't know how we're doing. You don't know how you're doing compared to other programs in the country. You don't know which one of these things to focus on. I showed you that they all have different sort of phenotypes and drivers, and so where should you start? So we run this quality collaborative in Illinois, and we have done a lot to sort of enhance quality improvement. And so we're taking lessons from what we've done there to bring process improvement to the learning environment. So again, Tony is really involved in this, and we have things where we put in surgeon mentors, process improvement coaches for each of the hospitals. We do projects together in step. We have collaboration calls. We do a lot to support QI across the state. And that's turned out to work really, really well. We have common data and between our hospitals, not only for the NSQIP data, but we also have very specific data to Illinois. And giving them their reports is very powerful. So can we transfer some of this to the learning environment? Similarly, can we give them coaches and mentors to help with that? And certainly, can we bring them together? It would be really helpful if you were working on sexual harassment to talk to some program that has worked on this previously and be able to work with them and hear about their approaches. How can we facilitate that kind of collaboration? Because it's really hard to know who might have worked on that. The other thing we do are these really detailed toolkits. And so the idea here, let's use VTE as an example. We say, you have a problem with VTE. We know that it's because your patients are refusing VTE. So you can go to that specific, or VTE prophylaxis. You can go to that specific spot in the toolkit and see what other hospitals have done. So there's actually a patient education module. There's a whole in-person training session that you can do with your nurses so they learn the speech of how to talk patients into their VTE prophylaxis. It's all sort of out-of-the-box solutions that you can just implement. You might have to tweak them a little bit to your local context, but wouldn't it be cool if we had that for wellness? Because right now you have to sort of just maybe you hear a little something at a meeting, but it's not organized and categorized. So we had a first trial, so we have to have a second trial, right? So the residents in our group, there's a competition for Cubs tickets to whoever comes up with the best acronym. So, so they came up with this recently, and I'll talk through a little bit about what the second trial is. So we've seen that there are differences in program culture. I showed you these sorts of bar graphs, or these box plots before. Can we go and look at the programs that are performing really well, and particularly those? We can also go look at the ones that are performing poorly, but here we're interested in positive deviance more than anything else. And can we look at what's different about their culture, their policies, their leadership, and their training to see what we might be able to transfer to other programs? In the survey this year, we got much more granular. We can probably be able to provide much more information about the types of exposures that are being experienced. But we want to create that toolkit, just like we did for VTE and for many other complications for this. And so we're going to go out to programs. We're starting with 20 or 30, but we may end up doing more. We have a group of psychologists, sociologists, residents, and a couple of faculty who are going to be going out to these programs to learn and see what they're doing. We're going to use the data to identify where we should go. We have data about who's doing it well. We're also doing a PD survey. You'll be getting that shortly to sort of show off what you've done to work on wellness. And then we're going to try to highlight those programs. And then we're going to do lots of interviews and focus groups with the key people in the hospital who affect the learning environment. So here's the benefit of a toolkit, right? So I just from what I've heard recently, I put this together. So Emory gives their residents, and I'm not saying this is the right thing to do, but gives their residents a half of a weekday off per week. If you were going to say they needed that to go do their, go to the dentist or get their brakes fixed or whatever it is, so that's what they did. Incredibly disruptive, right? So that totally threw up their coverage and whatnot. But they worked it out, they figured it out over the course of 2 years. If you thought that this was a solution that you needed based on looking at your program, this toolkit would have how they did it, what were the barriers they faced, how did they arrange coverage, and the contact information to call Keith, their program director, and ask him questions about it. So that's why this comes in handy. Similarly, Stanford has a post-call Uber account. I didn't even know you could do that. So how do you set that up? How much does it cost? What are the guideposts that they put in place? These are sort of out-of-the-box things that you'll be able to implement here to help tired residents if they don't want to drive home. The other one that was unique as well that I heard was Wisconsin put together a program for each one of their hospitals. They send their residents to a bunch of hospitals. They made it so moms can nurse. There's a specific spot. They sort of train the faculty to be able to talk about this in a comfortable way. That yes, sometimes your resident is going to just say, I'm going to step out the pump, and that's okay. Like they work through all this. So how do you do that? Again, the toolkit can help. So the idea is for the trial, if we give you your data and show you where you're doing poorly and where you're doing well, you can focus in only on the poor performing areas, get a little more detail from the drill down that we do in the survey, and then go to the toolkit. We'll bolster that with collaboration and coaching and all the things we talked about, experts. So this is the idea for the second trial. It'll be another national cluster randomized trial. And the question is, what's the intervention? Because all the program directors really want their data. So we have data on all the programs. They all want their data. So it may be how much of the toolkit and how much of the coaching and intervention that we do with the intervention on programs. We'll run it for a couple of years this time because it's going to take a little more time to change culture. That's probably not even enough, but at least that's where we'll start. Our primary outcome is going to be burnout. We'll measure all sorts of other things about job satisfaction, discrimination, harassment, duty hour violations. And then we're starting the program tours right now. The team is going to start these this month. And then, so that'll help with the toolkit. And we hope by early fall, we'll be able to release your program-specific report and the toolkit. There are a lot of concerns, any number of concerns with this. And so we put together Peter Angelos. He's one of the preeminent ethics focused surgeons. He has put together a team. He got to pick who was on it of ethicists inside surgery and outside surgery to come together and talk through all of these issues that we're working through on the second trial. Let me step through a couple of them. Am I 8:30? Is that
Yeah.
Okay. We initially thought, well, we'll give some programs their data and the toolkit, and some will just keep doing what they're doing. And the program directors did not like that at all. So they all wanted their data. Everybody wants everything. There's no proof that any of this works. I also sort of thought the same thing, but the intervention needs to be tested in some way. But they're unproven, some of them are expensive, and some may have unintended consequences. So there's some value in testing this. You can test it a number of different ways. You can do a cluster randomized trial, compare two arms like we did in the first trial. There's also this step wedge concept where you sequentially enroll programs over time, or groups of programs. And so the blue is the intervention part, but the time that they're not enrolled ends up being the control. The problem is it takes a long time to do that. Everybody wants to suggest this. Everybody that I talk to about these problems says, do a step wedge. That's the right way to go. But who wants to wait 2 years to get a program into this, right? We want to deal with this now. It's a problem now. We all want to get started. Why wait? So we probably wouldn't do that. There's the idea that we could just give everybody everything right now and give everybody the full court press. My team does not have the resources to necessarily support that for the collaboration and coaching. So we can't quite do that. The other thing is we'd never be able to tell if anything really improved because we don't have a control group to compare it to. If it improved, is that just the secular trend? That was going to happen anyway because everybody's interested in working on this. So the other piece of this I want to touch on because it's always important, confidentiality. So we get a lot of data on the residents and the programs, and protecting the residents and the programs is a primary responsibility. So if we did this and we provided programs back with their discrimination rate or their harassment rate, we would have some rules in place to limit when we provided that data. First of all, we wouldn't give you percentages, so you couldn't like backward convert how many residents reported and then try to figure it out. We would just tell you what quartile you're in general. The other thing we would do is occasionally you would just have an asterisk because you just don't have enough people to report that. You can imagine in gender discrimination, if you have only one minority and that person reported, and you were in the in even anything more than 0 on that, then you could figure that out. So we are focused on doing that. We've done that with the data through quality reporting and things like that. So we can do that pretty easily and protect the residents from our standpoint. For programs, one thing that's really important is the ACGME does not get any of this data. They are a funder, but they have never gotten any of the data. They see the publication level tables and figures in the journals that the rest of us all see. So they don't get any of the data. They won't use this for regulating programs or anything like that. They've made it clear that they're putting this to us. They're paying for us to do this because they want us as the House of Surgery to take this on. They like it a lot. They want us to take this and then offer it to all the other specialties so they do the same thing. The other thing I've heard as I've been talking about this for the last couple of months, and it's actually come from the residents, is like, work on our well-being, but don't ruin our training. Make sure that we are still well-trained surgeons. Don't give us more time on. That's not the key. And I think that's right. We saw that with the 16-hour rule. The interns hated the 16-hour rule in surgery. More time off was not the answer. So, but there are plenty of these interventions that we can implement that improve wellness, autonomy, the learning environment that don't deal with time off. But how do we measure that? Some of that is really challenging. So ABSITE scores are pretty blunt. We could do that through the surveys and ask residents if they're perceiving any difference, but that is obviously perception. We could look at board scores, but that's kind of too late. We want to find out earlier than whether they pass the boards or not to know. Do you guys use Simple here? The Simple app? No, I see. Okay, so it's an app that when you walk out of the OR, it texts the attending and says, can you fill out a quick 2-question evaluation of how the resident did? And there are about, I think, 30 or 40 programs now doing it in the US, led by Northwestern and Michigan. But is that something we could use? It still needs some validation. Could we do a subset study within the bigger trial of those programs to make sure that the wellness interventions didn't decrease their technical skills? That's only technical skills. It doesn't assess the judgment or anything else. So we're still thinking about this. This is an important thing that we need to maintain. So again, these people do all the work, and have to acknowledge them. But there's a lot to do in the second trial. We think we'll be announcing and enrolling by April. Is the goal, and then again by the fall we'll have the intervention started. I want to thank Dr. Bowl, Dr. Farmer, and certainly Dr. Goodnight. This is it's been a lot of fun to be here, and I'd be happy to take questions about any of this. Thank you.
Well, before he starts taking questions, I just want to take a minute to formally thank him. And we have a little token. I don't know if you noticed when you came in, we've that sort of interesting, it might have been too early when you brought him in, Dr. Bowl, but sort of our DNA.
Oh, yeah.
So that's kind of
Cool.
in the back of that. So it's important for you to have more stuff that you can put on your desk.
No, it's great. I just hope I hope they let me through TSA with this.
Yeah, so far it hasn't been a problem, but let us know.
All right, thanks.
But mostly I want to really thank you for that. And I have one question to start with is, are you only applying this at the present to general surgery residencies? Because obviously plastics, vascular, cardiothoracic are now separate surgical residencies, and are there any differences in those residents as well? So,
we have data on anybody who takes the ABSITE, so I don't think all of those residents do. Do they? No. Okay. So I think we're left with good data on that population. We'd love to expand it if we could. I think there'll be spillover effects undoubtedly. If we improve, if we put in a program for nursing moms, that's going to be great for any of the surgical residency programs, and it'll probably spill over to non-surgical. So we would hope that would happen. But you can imagine that in internal medicine, the solutions for wellness are totally different. They're mostly outpatient rotations. I'm not sure it's only 30 hours a week, but really, their needs would be totally different. So there will be specialty specific, but I don't know if that vascular cardiothoracic would be that different for residents.
it just would be interesting to ask a second time. All right, so we have time for some questions. Dr. Pokemon.
Really enjoyed the presentation. You've looked at the residents. How much do you think all of these things, if you looked at the faculty, would affect what's happening with residents? And have you thought about putting in an arm looking at the faculty?
We are certainly concerned about the faculty piece as well. The resident piece is one that we are sort of focused in on. We would like to do this with the faculty, and we were actually planning on doing it with the faculty until the ABS changed its certification mechanism, and so, but we may still be able to work something in like that. But I think we have to measure first and understand where we are with the faculty, and again, have targeted interventions, but certainly it's a huge problem for faculty. The drivers are totally different. We have far more control of our schedule and our work environment than the residents do, so I think the solution would be dramatically different. It's on our minds, but it's a big task to take on as for this, I think we're focused on the resident world.
Carl, sorry, that was a wonderful presentation. And the first trial was a wonderful study. And it seems like when you look at the medicine survey resident results and the surgery resident results, there's a difference in terms of their thoughts of the flexible hours, et cetera. And it brings up the question, do you foresee the ACGME the ACGME likes to look at all residents the same.
Yep.
All work hours the same, duty hours the same. Surgery being very technical, medicine not so much. Do you foresee a period of where there is difference in work hour requirements based on specialty?
Yeah, I think that's where they're headed. Tom Naska has said that he's not opposed to it. He's the head of the ACGME, and that there may have to be different common program requirements for sort of procedural specialties and I don't know, some other term for the medicine-based ones. I think they say cerebral, but I kind of bristle on that. Yeah.
Thank you for a great presentation. My question is, you mentioned that interns were more likely to be dissatisfied with the flexible hours, whereas more senior residents were more satisfied. You also talked about burnout. Now, have you looked at burnout and dissatisfaction between traditional programs where residents are introduced to the operating room in more like senior years versus apprenticeship model programs where the residents are introduced to the operating room like in the first year? And then have you also looked at burnout rates between like programs that are like part of like a county hospital or state hospital versus programs that have more money for support staff to help the residents?
It's a good question. So we haven't done the latter, but that we should look at. We've been thinking about how to get the information. It's a little murky because categorizing a program by how much apprenticeship they have is a continuous scale. So it's hard to categorize that exactly. Everything we've heard from the residents is that it would matter a ton. That's where the residents, when they flex as interns, are doing probably more scut, whereas when they flex as chiefs, they're doing during case. So I think that makes sense to us. I think we have to really protect that second and third year group, though, because I think they're in the ICUs. I think they're doing stressful work and not seeing the benefits necessarily of great cases just yet. And I think that's fairly universal, but I think that's a good point. We have not drilled down to categorizing how much apprenticeship they do, but I'm sure it would help.
Really enjoyed your talk. Just a couple things came to mind, especially in comparison of internal medicine versus surgery. Can you compare grit factor in those two?
Yeah, I mean, there may be a self-selection piece that occurs, right? So just from so we haven't compared them between the two, but you could imagine that's why internal medicine didn't want this.
Why imagine you got the data?
Well, we don't have it for internal medicine.
Well, you don't have.
We don't have grit data from internal medicine. They asked, we asked that in a subsequent year. They branched at that point and started doing other survey data. We can encourage them to capture that. It's a good question.
Just one last thing. You talked about all your programs and resident burnout. Another thing that struck me was that one of the biggest sources of discrimination and abuse is from patients and families. I mean, almost 50% of the problem is patients and families. Have you gone to administration with any suggestions that they could help with that end of things? Because clearly that's outside.
It may be outside, but it may not be. So you may imagine that you could train our residents to feel more comfortable when it occurs and to redirect, or to have that speech about how you deal with it in the moment, or the bystander. The male medical student, what does that male medical student say when the patient is talking to him rather than the female chief PGY7, right? So how do we train everybody to sort of work together on this? We can't change society, but we can sort of prep ourselves better, I think.
Great talk, Karl. Thanks for coming. Thanks for doing this important work. And you study a lot about the importance of the environment and the culture of the program. But you mentioned the second and third years might be in the ICU, and I remember starting with harassment training. It was pretty intense how sick the patients were. And you think about doing this on a day in, day out basis, and you think it gets really depressing. Having a huge ICU, patients who are dying every other day, And are there, how many patients or how many programs have, I don't remember ever having anyone come in and say, oh, you know, we want to talk about this case, or you want to talk about this death, or I just feel like we don't do a good job of dealing with that. Are any programs doing that well?
So some programs are, and that's, I think we'll get that in the program director inventory. It's one of our questions about how do you deal with residents experiencing stressful situations, complications, patient mortalities. And so we're going to try to find those programs and then go visit those programs to see what they're actually doing, and then hopefully have it ready to, you know, implement in other places.
I think people, you know, debrief when it's a huge crisis, right? When an unexpected death in the operating room, that, you know, there's sort of the action team comes into play to do that, and even at institutional level. But that chronic, everyday applications are done.
No, that's a good point.
Dr. Goodnight.
Dr. Bilimoria, it's absolutely an honor to have you here. What an incredible data set. Of course, like I say, you've got lifetime work, couple of lifetimes of work involved. Funding issues, labor issues. What about adding a longitudinal component to this for, like I say, a striking point like suicide rate in the first 10 years out of residency, leaving profession and so forth?
Well, plus, aren't half of the faculty going to be psychotic?
Yeah. Non-psychotic psychiatric issues.
I got really nervous about that.
Yeah, you know, there are lots of things that we want to study in the first 10 years after completion of training. It is very hard to get those data, but I think we need to develop systems to do that. We're starting to get systems in place where we can do that for patient outcomes, both, you know, getting faculty to fill out a survey, or, you know, even being able to find out if a suicide attempt or a suicide occurred is possible, or getting current data. So. I think we have to work on that. I think those are things we definitely want to work on. This issue of psychiatric issues after is very concerning if it's true. I really hope it's not. That'd be really high.
Dr. Camille, oh, yeah. Thanks, Dr.
Thank you so much for this. It's a lot of work you put in. And as you speak to the ACGME and look at it, as they're considering separating the medical specialties and surgical specialties and duty hours, is there any consideration for medical student applications and sort of keeping the workforce sort of going? Because as we separate them, we notice that it will probably change applicants into surgery and other specialties because it will be a significant difference in lifestyle. And is there any sort of thought to that as they start to consider this going forward?
So you're saying, should we ask the medical students who are interviewing for residency about?
Well, I just think it's going to change the medical students that are interviewing for residency that apply for different
If you go into internal medicine, you only have to work 40 hours a week.
Right.
If you go into surgery, you have to work 8
I
hours.
would argue that it's already happening. And Northwestern did not participate in the iCompare study because they said it would hurt us on recruitment day if they thought we could be in the
And is there any thought, that's what I'm saying, I'm pretty sure that already
Yeah.
happened. Is there any thought that and actually looking at it and then looking at it for future workforce?
Yeah, I think that gets back similarly to the grit question. Should we be measuring grit in residents? Can we understand the difference between internal medicine? It's a great line of inquiry. I think we should start to do that. I think it's already happened so much that I think it's over. I don't think we're going to convince surgically minded people to go into medicine or vice versa.
No, but I do think that the whole concept of the surgical workforce and expectations around hours and how we work as faculty, as attendings, has been addressed in some health systems in different ways that I think the academic health systems may be a little bit later to the
Right.
game in terms of changing that work life for professionals.
Yeah, there's one number from the iCompare study that is atrocious. 13% of a resident's time, they actually had people following the residents in a small subset. 13% of their time was on patient care, actual patient care. The rest of it was on something else. I think we're lucky that we don't have that problem. We have a much higher percent of our time taking care of patients. So it's good parts of that.
So I can't help but, we'll have one last question with Dr. Campbell, but I want to make the comment that there's not one resident who has raised a question here so far. It's all been the faculty. I can't help but notice that. I will say that the residents are going to have an opportunity to spend some time with you immediately following this, and I hope that turns into a different kind of conversation than we've had. And I'm a little anxious about the fact that none of you spoke all about asking questions here. So we'll have to delve into that on our own. But the residents are going to have some time with you afterwards. Dr. Campbell.
Yeah, really nice talk.
You're close. You're the closest. One of the closest guys to being a resident.
To being a resident. Yeah. I got the beard.
Yeah, exactly.
Actually, I want to dovetail on that thought, and that is the role of the faculty in all this. And specifically, have you looked at faculty's impression of work hours and how that affects residents, faculty's burnout rates and how that affects the residency burnout rates? In other words, as faculty, are they simply emulating us? And what can we do to make this better as a policy?
Or is it the stress that you faculty feel that is then pushed onto the residents or taken out on the residents, right? So it could be that we have not measured the faculty piece. I think it's worth doing. Again, it's just complicated to get people to respond. We probably do have to move that way if we're going to start to understand this better. I would like to do it. It's a whole other undertaking. This one's not but I think it's absolutely right that we as faculty have to take this on. In the flexibility trial, we said, we do have to change how we think about how we take care of the residents. It's flexibility to stay and take care of patients, but it's also flexibility to leave. That old concept of staying until everybody's done in the OR needs to be abandoned. We need to send people home when there's not stuff going on and maximize those hours. But similarly, the faculty are going to have to adapt, and hopefully seeing how other programs have done it will help. Lessons from the toolkit.
Yep. Great. All right. Thank you so much. We appreciate it.